Implantable cardioverter defibrillator, known in short as ICD, is a device which monitors the heart rhythm continuously and treats it electrically when needed, as it functions automatically without the need for a bystander intervention, as in case of automated external defibrillator or AED. It is also known as automatic implantable cardioverter defibrillator or AICD. When Michael Mirowski reported on a standby automatic defibrillator in 1970, it was met with a lot of skepticism. But now, ICD is time-tested, life-saving equipment. The most commonly implanted ICD is also called transvenous ICD because the leads are introduced through the veins into the heart. A purely subcutaneous ICD with lead implanted subcutaneously in the left parasternal region is also available. Recently, an extravascular ICD has been tested with a lead in the retrosternal space with performance better than purely subcutaneous ICD and almost nearing the transvenous ICD. These new types of ICDs have been innovated to avoid the potential problems with transvenous leads in the conventional ICD system. Leads in the vascular system can get infected, can get fractured or dislodged, and occasionally perforate the cardiac chambers. Lead can also lead to intravascular thrombus formation. For these reasons, lead has been called the Achilles heel of most cardiac implantable electronic devices, which include pacemakers and ICDs. The ICD system consists of a pulse generator with battery, usually implanted in the left infraclavicular region for transvenous ICDs. Pulse generator is implanted in the left axillary region in case of purely subcutaneous ICD and extravascular ICD. Left-sided implants are preferred because ICD shocks will be more effective with an ICD pulse generator can on the left side. ICD pulse generator can is one active electrode, while high voltage coils located in superior vena cava and right ventricle are the other active shock electrodes for a transvenous ICD. An important disadvantage common to all types of ICDs is an inappropriate shock. This could make up 1/4 of all shocks, and there are ongoing innovations to have better diagnostic algorithms to avoid inappropriate shocks for a supraventricular rhythm. Oversensing of T waves and sometimes P waves, as in case of extravascular ICDs, can also cause an inappropriate shock. The pain caused by inappropriate shocks can cause psychological problems as well. Though the appropriate shocks are also painful, at least there is a relief that a potential sudden death has been averted. Overdrive pacing for ventricular tachycardia is an option available in transvenous and extravascular ICDs, but not in purely subcutaneous ICDs. Overdrive pacing is a painless form of treatment for ventricular tachycardia, which is not too fast. Most ICDs can be programmed to try overdrive pacing when the high voltage capacitor is being charged for shock delivery. If overdrive pacing is able to terminate the ventricular tachycardia, a shock is averted. All fast ventricular tachycardias and ventricular fibrillation usually receive shock as the first option, though overdrive pacing has been used in fast ventricular tachycardia as well. The battery life of the ICD depends on the number of shocks it is called upon to deliver and the energy levels needed for each shock. Antiarrhythmic drugs can be used to suppress ventricular tachycardia to reduce the potential need for shocks, but there is a caveat. Breakthrough ventricular tachycardia can occur at a lower rate, below the programmed detection rate of the ICD. Recurrent slow ventricular tachycardia has a potential to cause tachycardiomyopathy. Antiarrhythmic drugs can also increase the defibrillation threshold and require higher energies for a shock to terminate VF. Another option often used to reduce the number of ICD shocks is mapping and ablation of potentially ablatable tachycardias. This does not have the disadvantages mentioned in case of antiarrhythmic drugs, but mapping and ablation may not be that successful in case of ischemic VTs with multiple circuits related to the border zones of myocardial scars. Similarly, mapping and ablation have only limited role in those with certain cardiac channelopathies. ICDs can be given both as a primary prevention and secondary prevention. They are given for primary prevention of sudden cardiac death in those with cardiac channelopathies with a high risk of life-threatening ventricular arrhythmias like Brugada syndrome and long QT syndromes. Post-myocardial infarction left ventricular dysfunction is another potential indication for primary prevention. But in this case, the utility of the device may not be that high even though studies have documented benefit. Secondary prevention after resuscitated sudden cardiac arrest and in those with recurrent life-threatening ventricular tachyarrhythmias are situations in which ICD implantation cannot be avoided. Implantation of ICDs can be under local or general anesthesia. If defibrillation threshold testing is done, general anesthesia may be better because of the pain involved. But for modern ICDs with good performance, defibrillation threshold testing is seldom a necessity. For defibrillation threshold testing, VF can be induced by a low energy shock delivered on the T wave. Defibrillation threshold testing is not without risks, as occasionally the induced VF may be refractory, sometimes requiring even simultaneous defibrillation with two external defibrillators at full energy. Good follow-up programming is a must in case of ICD. ICD interrogation is needed after each shock to ascertain whether it was appropriate or inappropriate therapy. Programmed parameters like zones of therapy, types of anti-tachycardia pacing cycles may have to be revised depending on the interrogation results. Interrogation is also needed to check battery status. Recorded events can give an idea of the types of arrhythmias, including atrial high rate events or AHRE, which have been considered as surrogates of atrial fibrillation. With modern ICDs, remote follow-up is also possible with basic data from the ICD being transmitted over a wireless network to a physician located even in another continent. But changing programmed parameters will need a visit to the nearest specialist center. Wireless access to medical devices has always raised concern about unauthorized malicious access. Potential complications other than those related to the leads as mentioned earlier and inappropriate shocks are those related to device pocket. In the early period after an implantation, pocket hematomas can form, especially in those on antithrombotic medications. Hematomas have a potential risk of infection and may occasionally need surgical drainage. Erosion of device from the pocket is another potential problem. Device pocket infection is another dreaded complication which may require device explantation and implantation at another site after control of infection. Another concern about ICDs is during end of care life. There may be situations in which ICDs may have to be inactivated in a near terminal condition, raising ethical concerns. Like a pacemaker, ICD has to be explanted when cremation is being planned. Care has to be taken to suspend ICD therapies by programming to avoid shocks to the persons doing the explantation. In other situations, like while surgery using electrocautery are being planned, it is possible to suspend ICD therapy by applying a magnet over the ICD when a programmer is not available. Precautions with electromagnetic radiation and magnetic resonance imaging are applicable to ICDs like pacemakers. This is only a brief overview about ICDs as the topic is very vast with so many ramifications. Here are a few journal references. Thank you for watching this video. Please subscribe, like, share, and post your valuable comment below this video. Kindly press the bell icon after that for getting all updates.